All right. So thank you everyone for joining today's webinar. Dr. Elizabeth Morrison-Banks will be hosting today's webinar with an introduction to multiple sclerosis. She is a clinical professor of neurology and is also a practicing physician at UCR Health. I will let her introduce a few more of her accolades as she's very well renowned. But if you do have questions, please submit them via chat and we will be sure to get to them at the end of the presentation. And again, if you do have any comments, or be sure to share them in chat. So with that, thank you so much. And I'll hand it over to Dr. Morrison-Banks.
Thank you, Stacy, and thank you so much for helping set up this session. We're really excited. This is our first session in a series about multiple sclerosis. And I know some of you in the group who've joined today, and I'm really excited to meet the rest who I haven't met yet. And in addition to what Stacy mentioned in terms of my background, I'm also director of the UCR Multiple Sclerosis program. So this program is a comprehensive MS care center recognized by the National Multiple Sclerosis Society, and there are still fewer than 10 of these centers, I believe, in the state of California. So we feel very fortunate we're able to be one of those centers, and this is what we do all the time, do our best to help people living with MS and their families to have the best possible outcomes with their MS. So I wanted to mention also before we start that with the screen sharing mode that I'm using, I can't see the chat. So I would love to make this as interactive as possible. So I'm okay with it if you are, Stacy, if people in the group today had questions and they wanted to ask them as we go, rather than waiting until the end, I'd be fine with people taking off the mute button on your audio and just asking the question. Is that okay, Stacy, or do you prefer?
We can definitely give it a try. I have a feeling you might have quite a few questions, so possibly we'll give that a try. If not, we could also have people submit questions in chat, and maybe every couple of minutes, I'll just let you know we have some new questions.
Oh, right. Okay, and then you could read the question off to me.
Absolutely.
Either way, yeah, so we'll try to make it as interactive as we can.
Wonderful.
So, I figured I would just give you a little intro to MS, and then we can leave time for questions, plenty of questions during and at the end for sure. So here's a little bit about MS. So and some of you know some of this information, but I think it's always good to review it and talk about it together. So it's the most common cause of non-traumatic disability in young adults in the US. And I think the key point I'd like to emphasize today is that if we can diagnose MS early and treat it, that often helps to prevent or slow the progression of neurological disability. So that's the goal. Everyone wants to have as little disability as possible. But if you do have neurological disability from MS, the other important goal is to learn to deal with it and manage symptoms so you have the highest possible quality of life. So a lot of advances have been made in all of these areas recently, and that I think so there's a lot of reason for hope and optimism for the future. So when we talk about the prevalence of MS, we're just talking about how common it is. So in the US, they used to say, and some of you might remember this figure, that there are approximately 400,000 people in the United States living with MS. And that number hadn't really been changed for decades. So it was based on older data. So in 2017, a research group did a new study, and they actually used health claims databases from insurance companies to get more accurate estimates. And it turns out we were off by more than 50%. So they're actually closer to 1 million people with MS in the United States, and even more around the world, of course. So very interesting. So it's more common than people thought. And if you think about the worldwide distribution of MS, that's very interesting too. We're in an area of high prevalence, but not as high as northern latitudes of North America and Europe. So these red areas are the highest prevalence. And you can see it, the closer you get to the equator, the less common MS is. And we don't know exactly why this is, but we do think that I'm going to skip ahead to this slide. There are different factors that trigger people to develop multiple sclerosis, and some may be environmental. So, I mean, there's some genetic link, but not that much actually. So even people who have a twin sister or brother, and one of the twins has MS, more than half of the time the other twin never develops MS, even identical twins. So you can see that there isn't that big a component of genetics. Environmental factors seem to be a bigger component. So it depends. Prevalence of MS has a relationship to where people grew up for the first 15 years of their lives in particular. So if you grew up in the northern latitudes, you're more likely to have MS than if you grew up closer to the equator or in Southern California. However, we certainly in our practice take care of lots of people who grew up right in this neck of the woods and have, didn't live up north and didn't come from a typical ethnic background that would predispose them a little more to MS, and that's often Caucasians, people of Northern European ancestry. But MS can affect people from any ethnic background, any part of the world, male and female. It's certainly more common in women than in men, but there are plenty of men living with MS too. So we just have to throw out all those stereotypes and assess each individual. There's also a component of infectious agents as a potential trigger for MS. And it's not so much that, one particular infection like Epstein-Barr virus, for instance, causes MS, but it seems to be when you get exposed to infectious agents. So there seems to be a pattern of people growing up in northern latitudes where they're indoors in the winter and maybe getting exposed to infections at an earlier or later stage in childhood. It's all very complicated, but there's not much we can do about a lot of these factors. So it's just interesting to note, I think. So the other part I wanted to mention about epidemiology of who gets MS and what their MS is like when they're diagnosed is this slide. So I'm sure most, if not all of you have heard of relapsing versus progressive MS. There used to be more categories, and some neurologists still try to differentiate other categories. But I think it's helpful to say it's either relapsing, where you have attacks of symptoms that come and go, versus progressive, where it's more of a steady increase in symptoms over time without separate relapses. And at the time people are diagnosed, 8% or so have relapsing MS, and 20% have progressive MS. So I won't go into great detail about the science of all this, but I think a little bit is interesting to hear about. So when we talk about what starts MS, pathogenesis means how the disease gets started. What's the mechanism? And it seems to have to do with inflammation. So MS is an autoimmune condition in which the immune system attacks its own central nervous system, the brain and spinal cord. So it's not, sometimes people think of MS, when they hear about it, they think MS is a weakness of the immune system, but actually the immune system is hyperactive and it's doing more than it should. It's not just trying to attack infections and get them out of the body, it's also attacking the body itself. And so we've known for a long time that it's an inflammatory condition where activated T cells, they're T lymphocytes, a type of white blood cells, they become activated and they cross the blood-brain barrier in the brain and the spinal cord. So they're not supposed to be able to do that. And when they do, they cause a lot of the typical symptoms of MS when they get into the brain and the spinal cord. So this inflammatory process, when MS is in its earlier stages, in the relapsing phase, the MS tends to cause, and I'll show you later on a slide of MRI findings, inflammation, causes some white matter lesions usually or white spots on brain MRI that light up with gadolinium contrast. When you get the MRI with contrast, that's the purpose of the contrast, is to show how inflammatory those lesions are. And over time, though, this inflammation can lead to axonal loss. And what does that mean? So the nerve cell has different components. We have nerves, the brain is full of nerves, and the spinal cord has nerves coming off that provide sensation and movement and other functions all over the body. And those nerves are wrapped in a sheath of myelin. That's why MS is called a demyelinating disease. So when MS attacks the myelin, it can over time start not only interfering with that sheath around the nerve, but the inside part of the nerve called the axon is also affected. So if you think of it like an electrical cord, the myelin is the insulation around the cord, and the axon is the wires that actually conduct electricity. And it's very similar in nerve cells, or neurons or nerve cells. So these cells can get destroyed over time, and this causes atrophy of different types of tissue in the brain and the spinal cord. In the beginning of the disease course with MS, there are demyelinating episodes where the myelin gets damaged, and then those areas tend to remyelinate and grow back. And that's why, if you have an attack of MS, and especially if you receive treatment like intravenous steroids, that attack tends to improve. And sometimes it improves even without treatment, especially in the beginning of the disease. But over time, that remyelination occurs less. So we try to, this is all what we're trying to prevent. And here's another slide about different symptoms that people have with MS. So has anyone heard this called an invisible disability? If you haven't, I think it's a helpful term because it's easy to see the visible symptoms if someone's having a relapse and they're unable to walk, or they have, they're using an assistive device. That's visible to the world at large. But sometimes some of the symptoms are invisible. Some of the cognitive changes that about 50% of people with MS have to deal with. Brain atrophy can be occurring even early on in the disease course. And MRI lesions, you can see them if you look at your MRI with your physician, but others wouldn't know that you had those lesions unless they were looking at your MRI. So it can be frustrating sometimes to have these invisible symptoms that other people can't see directly, because they might think, why are you using that disability placard on your car when I don't see you using a wheelchair? Well, not everyone who has a disability in walking is going to need a cane or a wheelchair, but they still need to be able to park closer to the entrance to the store or what have you. So I think it's important to be sensitive to the fact that not all these symptoms are visible. This is just another slide on types of MS. Some might have heard of secondary progressive versus primary progressive MS, of the two subtypes of progressive MS. And we don't need to go into great detail, but I just wanted to point out, we used to have treatments only for relapsing forms of MS, but now, fortunately, the FDA has, in the past few years, since 2017, actually, it's only been about 5 years now that we have a new treatment that's FDA approved for primary progressive MS in 2017. And then since then, there's some FDA approved treatments for secondary progressive MS, at least the active variety, where people have had attacks in the past couple of years. So that's, I think, really exciting progress. So in summary, MS is more than a demyelinating disease that affects myelin. It can cause brain atrophy like this and loss of those axon components of the nerve cell that cause more permanent damage. So if you see in this slide, this is an MRI of the brain with the cuts looking across like this. And you can see the progression over time where these ventricles, this is where the cerebrospinal fluid flows through and covers the brain and spinal cord. These areas should be small like this, but they get bigger and even bigger as time goes on. And it's not because they're swelling or there's something causing this area to directly enlarge. It's more that this tissue is starting to thin out, and so these ventricles expand to fill the vacuum. So MS symptoms, and if some of you in the group are living with MS or you have a family member who is, or a friend, a loved one, you are probably familiar with a lot of these symptoms. The most commonly reported symptom is fatigue. A lot of people have fatigue who don't have MS, but there's a type of MS fatigue that is more common. Usually it's more sleepiness. Some people feel exhausted too, but people say they feel sleepy and it comes on suddenly at the end of the day. Bladder and bowel dysfunction, sexual dysfunction, sometimes cognitive impairment that, as I mentioned, occurs in about half of people living with MS. And it can vary in severity, it can be quite mild, but some people get actually a form of cognitive fatigue where when they get tired, they don't perform as well on cognitive tasks. So sometimes it helps to do those, like if you have an important task you have to do to get it done in the morning or when it's cool out, it's not too hot. Some people get heat sensitivity too that affects all these symptoms. Even a 1 degree increase in body temperature can increase MS symptoms temporarily. Depression is more common in people with MS, actually more common than in people who have other neurological diagnoses that have a similar level of neurological disability. So there's something about MS itself, the types of lesions that people get in the brain that must cause more depressive symptoms. Not everyone has this issue, but if you do, it's not uncommon. Numbness and tingling, very common. Weakness. It's often on one side of the body or in the legs, or can be arms or legs or anywhere really. Balance impairment, vision changes can be double vision or impaired vision if someone's had opticneuritis. Muscle spasticity, meaning muscle spasms or stiffness, which can be painful. And then some people get pain from, there's more of a nerve pain that people tend to get, which is more of a burning, shooting pain with numbness. And that's caused by the nerves themselves rather than the muscles. And some people get both types of pain with MS.
Dr. Morrison-Banks?
Yes.
So we have a few questions if you're up for it.
Oh, I'm up for it. Sure, absolutely.
Okay, perfect. So the first question came in and they asked if UCR has a support group for family members of people living with MS.
We haven't yet offered a support group ourselves, but, well, two things. There are some great support groups that are sponsored by the National MS Society, peer support groups. And one of them is at Riverside Medical Clinic, and it's very good. And there are others in the region, and the National MS Society website can direct you to those. However, I would say that if there is interest in having a support group with UCR, I would be very open to discussing that. So, you know, we can, is there a way, Stacy, we could provide an email address? I mean, I'm happy to provide mine.
I'll provide an email address in the chat. That way, for those who are interested in a support group, or if you have questions after the presentation, for example, you can reach out.
Yeah, and we could talk about, you know, whether if there's enough interest, we could certainly, for one thing, in this series that this is the first session in this MS series that UCR Health is sponsoring. We wanted to, in future sessions, have make them more small group discussion sessions. And that almost verges on a support group. It can provide a lot of support too. So we can certainly start with that.
Perfect. The next question, and I'm gonna mispronounce one of the words, but with regards to steroids, is this the only way remyelination can occur?
Oh, I'm glad you asked that. So not necessarily. Sometimes this remyelination occurs even if you don't receive steroids. So trying to find that slide. Yeah, so the steroids do, if there's inflammation going on with an MS attack, the steroids do help speed up the remyelination. And it's possible to receive steroids. They're usually given intravenously with IV infusions. But if for some reason, especially during the pandemic, someone cannot, there's just no way they can have an infusion. And I've had people decline infusions this year just saying, I just don't, it's not worth it to have someone come over. I'm worried I'm going to be exposed to COVID-19. It's possible to give the steroids by high dose oral route. So we're talking about much higher doses of, say, prednisone, an oral steroid, than we usually give. So not talking about 60 milligrams a day, but 1,250 milligrams a day for 3 days. So that's an option you could talk about with your neurologist if it comes up.
Thank you. We have 3 more questions, and then I'll let you take over again. What is the percentage of people who transition to secondary progressive MS? Was that the 30% slide?
Oh, thank you. So this slide is showing the percentages at the time of diagnosis. So it's about 4 to 1 relapsing to progressive MS at the time of diagnosis. However, that does change over time. So within 10 to 15 years after the diagnosis of MS, about 50% of people will have gone on to develop progressive MS. So including that 20%, another 30% will, by 10 to 15 years out after their diagnosis, have progressive MS, if that makes sense. So over time, progressive MS becomes more common.
Okay, thank you. The next one is, do you recommend any certain diet or lifestyle changes in people with MS in addition to medication?
Oh, absolutely, yes. And I think we have a whole session, do we not, Stacy, that's going to be devoted to that topic. So this is great. This will be a great preview. Definitely. So one thing I think is really important is diet. So we used to say that diet didn't really affect MS outcomes. And I don't know if anyone in the group, and you don't have to answer this publicly if you certainly, we're not asking anyone to volunteer information that they don't want to share, but some of you may have had MS for a long time, and you might know of, there used to be a popular diet called the Swank diet by Dr. Roy Swank from the Pacific Northwest, who's an MS specialist. And it was very popular, but we didn't have a lot of data supporting it. And now we can see Dr. Swank was probably right, that diet is important. So there's been more and more research in the past few years looking at what you call the gastrointestinal microbiome in MS. So this is all the flora, bacterial flora that live in the intestines, and there are billions of them. They're very numerous. And they aren't just bacteria, they come in all different shapes and sizes and forms, and everyone has their own blend of bacteria in the colon, in the GI tract, that it's kind of like a personal version that everyone has. And in studies of people with MS, those bacteria, the populations of bacteria seem to be different in many cases from people who don't have MS. So the upshot of all this is you want to have the healthiest possible population of bacteria in your GI tract, and the way to do that is with diet. So the diet that I usually recommend is either a Mediterranean diet, or a modified paleo diet. So more plant-based, more fresh fruits and vegetables, whole grains rather than processed foods, healthier fats, less sugar, less salt. I know sounds like I just took away all the fun foods, but this is also a healthy diet for people who don't have MS. It's probably, they say we should be eating, the idea of the paleo diet is you're eating what cave people used to eat more than we do now with all our modern conveniences. So diet's really important. The other thing that's super important is exercise, and aerobic exercise as often as possible. And if it's possible to get 30 minutes of aerobic exercise, at least 3 days a week, most days out of the week, even better, that's great. And some people will say, I can't do that. I get overheated. I'm heat sensitive. My MS symptoms get worse after about 15 minutes or 10 minutes. There's no way I can do 30 minutes. I hear you. That is an issue, but one thing you can do is to split up the exercise. So you're getting, 15 minutes in the morning and 15 minutes in the evening. You're also avoiding hopefully the heat in the middle of the day. Pool exercise, like aquatic exercise, aquatic aerobics, or there's even aquatic physical therapy is helpful. And some people who have more neurological disability might need physical therapy to help get started. They can actually give you an exercise prescription to help you exercise more safely. So I think those two factors, certainly in terms of diet, also vitamin D intake is very important. And I recommend people have adequate levels of vitamin D. It does improve MS outcomes. If you have progressive MS, there's evidence for biotin supplements. It's another vitamin that is associated with better outcomes with progressive MS, and then just a healthy diet in general. So I hope those tips are helpful.
Thank you. And then one more question before we hand it back over. What are your feelings on acupuncture or chiropractic therapy?
I think that's great. Whatever works for you. There's some evidence supporting these kinds of alternative modalities of therapies. And I think you just, like anything, you have to have a good practitioner. If you try to find someone who knows about MS and has worked with people with MS before, I think that's helpful. And it really just depends on what they're doing. Your results may vary depending on what your specific goals are for symptom management. Okay, well, good. So shall I keep going then? There aren't too many more slides, but I wanted to highlight some of the common ways that MS tends to present. And this often happens early on in the disease course, and it might be a first attack opticneuritis. So it's characterized by sudden loss of vision. It could be partial or complete in one eye or both. It tends to evolve over hours to days, and you tend to have pain with eye movement. And interestingly, only about 50% of people who have a first attack of optic neuritis go on to develop MS. But we know that, like we were talking about IV steroids before, they do hasten recovery from optic neuritis, from this optic neuritis treatment trial. But they don't change whether it's going to turn into MS or not. But it's good to know. Transverse myelitis, many people have had this who live with MS. It's caused by a lesion in the spinal cord. See, in this MRI, you see all this white area that shouldn't be there. The spinal cord should look smooth like this part. So this is caused by an MS lesion, and it causes progressive numbness and tingling on both sides of the body below this level. This is in the cervical spinal cord in the neck. So it's going to cause symptoms probably in the arms and legs. Many people recover completely. Some have more disability. And again, sometimes this only occurs once and the person doesn't go on to develop MS, but it can recur. And for many people with MS, this might be their first attack. And when someone's getting diagnosed with MS, there are other causes of white spots on the brain MRI. especially people who are older and have vascular risk factors like high blood pressure, diabetes, migraines, head trauma if someone's gotten hit on the head, that can leave spots that could look like MS lesions. Lyme disease, that's supposed to be a tick. HIV, less commonly. Other inflammatory conditions can mimic MS, so it's important to look for those. So I won't go over this in detail, not before lunch. I'll put you guys to sleep. But there are lots of components to the diagnostic criteria. I just want to show how complicated the diagnosis is, and it can be frustrating when you're going through the diagnosis process because there's no single study that confirms necessarily that you have MS. You have to have a typical history that shows MS lesions spread out in time and space, like not just one attack, like we talked about a couple minutes ago, but usually more than one attack, or one attack and MRI lesions that are diagnostic. So most people certainly in the developed world will get MRIs to help with the diagnosis. Some need a spinal tap, not always. And the blood tests are to look for non-MS causes of the symptoms. And then there's some special tests like optical coherence tomography, or OCT, is a test that looks at the thickness of the retinal nerve fiber layer in the back of the eye. And it can be useful for diagnosis, and also sometimes, if it's hard to tell otherwise, and also for monitoring how people are doing. For instance, people with progressive MS, I think it's helpful to follow along with an ophthalmologist who can do this OCT over time and see if that retinal nerve fiber layer is staying healthy or declining. So here's some MRI findings that I think are useful to look at. These are different types of MRI sequences, and you can see these white areas are typical of MS. These lesions, this is a post-contrast sequence, and these are lesions, these white areas that are lighting up with contrast. So these mean newer, more inflammatory areas, lesions that have been present only for as long as 3 to 4 months maximum. And then you see these dark areas here, these are black holes, and these are areas where the axons have been destroyed, and they are permanent losses of nerve cells in those areas, and they correlate more strongly with progression of disability. I don't know if anyone's heard of Dawson's fingers. They look like finger-like projections. This is a side view MRI, and they show where where the blood-brain barrier is. And these are typical areas for these lesions. And there's another picture of black holes. So I think it's helpful, by the way, to ask your neurologist to go over your MRIs with you if you haven't. I think it can be helpful if you're interested to see these. So why is it so important to identify MS early? And the reason is, if you treat it from the time of diagnosis, outcomes are better. Means less disability, and going up it's more disability. Then it's better to treat from diagnosis compared with treating later or not at all. This natural course of disease is like what we would see in people who got diagnosed with MS 40 or 50 years ago, and there was no treatment available. Now we do have treatments. And some common questions. MS doesn't greatly decrease life expectancy, maybe a few years. On the average, it means for some people it doesn't decrease life expectancy at all. However, we want to be careful if someone has a lot of other medical conditions, especially vascular conditions. Those can worsen health outcomes in people with MS, because having MS doesn't protect you from these other conditions. MS and pregnancy, we take care of pregnant women who have MS all the time, and very low rates of transmission of MS to children. So having MS isn't a reason not to get pregnant if you want to have a family. And there are very few pregnancy complications in women with MS, but because actually the estrogens in pregnancy are protective when you have MS. The issue, though, is that MS attacks can occur right after the baby's born, or right after the baby stops breastfeeding. So the estrogen levels drop and you can get an MS attack. So it's important to be ready to go back on MS disease modifying therapy afterward. We talked about this a lot already. So exercise, beneficial, encouraged. And a lot of people will say, oh, I was just diagnosed with MS. That means I'm going to need a wheelchair. Actually, only about 1 in 4 people with MS are ever going to need a wheelchair, and only about half would require a cane. And some people require a cane for other reasons as they get older anyway. But to improve these numbers, considering early treatment is helpful. So there's this concept now of treatment induction with a highly effective disease modifying therapy. The goal being, quote unquote, no evidence of disease activity. It's hard to sustain that goal, but it's admirable. And just, I think it's important to recognize that relapses and disease progression are probably occurring all at the same time, even invisible relapses. And so I hate to call anything a true remission because we don't know what's going on under the surface. So just more reason to consider treatment. And those who've had MS a long time will recall these first injectable therapies getting approved by the FDA in the 1990s. Natalizumab we still use all of these, including natalizumab, which is an intravenous infusion. It's once a month. Then in the 2010s, a number of oral therapies came out. Alemtuzumab is a immunosuppressive infusion. Ocrelizumab is another infusion. And then siponimod and cladribine are fairly new oral treatments that have come out. Then some even newer ones. You can see the pace of these treatments getting approved by the FDA has accelerated. If we go back, there were only a few every few years getting approved, and then the pace started speeding up, and now, bam, look at all that. Just in 2020, and 2021's already had ponesimod get approved. Some of these are very similar, the ones that say fumarate. They're different variations of dimethyl fumarate. But I'm happy to talk about anything you like. I did want to mention, when we take more questions, I'm happy to talk about anything you like. I want to mention quickly with symptom management, we talked about some of these symptoms already, but I'm happy to talk about treatment of symptoms and also resources. We have an MS center. There are other MS centers. Loma Linda has a nice program. The National MS Society has wonderful resources and a great website, including they have a web page that's devoted to the COVID-19 pandemic, vaccines for COVID-19 and how those relate to MS and different treatments. They have a whole comprehensive list of all the MS disease modifying therapies. And then beyond resources like that, there are other organizations too, Act for MS, the MS Foundation. There's several great resources. Then other practitioners can often help. We talk about physical therapy. Occupational therapy is for hand and arm issues that can happen to some people with MS. There's speech therapy. Then physical medicine and rehabilitation is another medical subspecialty that can help with working on optimizing functional capacity for those who have disability. A lot of our patients with MS will see a urologist. Some of the women will see a urogynecologist, and they specialize in neurological bladder issues. We mentioned ophthalmology, how important they are. We also have, by the way, at UCR Health and at other centers, there are neuropsychologists. We're very fortunate to have David Franklin, who's a PsyD, has the PsyD doctoral degree. He has special training in neuropsychological testing, which is very helpful. And we have an MS nurse practitioner, Lindsay Lakin, who works with me, and also another MS specialist neurologist, Dr. Jay Rosenberg. So we have a good team, I think, of practitioners and an infusion program with an infusion nurse. all of us specialize in MS, and this is true at other MS programs too. And there are other programs in schools and the community that can be helpful. So that's all I have as far as slides, and I'm happy to answer other questions or have any discussion back and forth if we want to do that. However you say we should do it, Stacey.
Wonderful.
Awesome. Yeah.
If you'd like, go ahead and end your presentation, and then we have a few questions that might be easier for you to read in the chat. So let me know if you see the chat, and then I'll let you know the one that you can start with.
Oh, great. Okay, so I go to the top. Oh, yes. And as before I address questions, I wanted to thank Katrina Williams. Since I self-identified Katrina, I can say I can recognize you. And Katrina is the leader of 2 different National MS Society support groups meeting by Zoom. And there's this information. I highly recommend this. Katrina, you're great. It's she's a wonderful support group leader. Oh yeah, there you go. Swank diet. I should go to the top. Oh, okay.
We can actually start with Olivia at the 12:37 because you've addressed all questions above already.
Oh, I did all that. Okay, that's great. Didn't I? 12:37. Okay. Okay, so testosterone can help. Oh, that's interesting. I think that, it's hard for me to address it specifically for Olivia as an individual or any individual medical questions, only because I, won't know your history or won't have examined you and wouldn't be able to give. So I'll just answer in general, if that's okay. I mean, it's a great question. I would say, it would be pretty hard for me to answer it specifically, but I think it's important to have a primary care physician who is addressing issues like this, because it's like those other medical issues we talked about, vascular risk factors, for instance, they can affect MS. And I don't know, I think it would be really important to get follow-up with this. And if your primary care physician needed to refer you to another specialist in this area, that might be a good thing to consider too. And thank you for asking. I wish I could have answered it more specifically. And someone commented on having psoriatic arthritis, then developing MS, went into complete remission during pregnancy. That's a great story. That's very common. That during pregnancy, symptoms improve. There, researchers, the question is there a way to trick your body into thinking you're pregnant? Would it help? And that's a great question. The researchers have tried to address that. Rhonda Voskul and colleagues at UCLA actually did a study of estriol, which is an estrogen preparation, and they gave it to people with MS, women. Might not be a healthy thing to even try this with men because they're not supposed to have high estrogen levels in general. But the problem is that estrogens work, but you have to give high levels of estrogens, and they cause morning sickness, like when people are pregnant. So it turns out that the downsides of using high dose estrogens probably outweigh the upsides. So I would say though, if someone has a need of birth control and for other reasons wants to use estrogen, like birth control pills, that might be, maybe there's some modest benefit for MS as well, but I wouldn't use estrogen just for that reason. Just for MS, I would, if you had another reason to use it, I think it might help. And another question, oh yeah, how optimistic am I about remyelinating drugs? Oh, I'm so glad you mentioned Professor Seema Tewari-Woodruff. So she is another team member I neglected to mention, I should have. She's a researcher. She has a lab on the main campus at UCR, and she studies remyelinating drugs. And Iqbal's question mentioned indazole chloride, for instance. I think this is wonderful. I'm optimistic. So when Dr. Tori Woodruff and colleagues study agents like this, they have to start from the very beginning. So this is when they're looking at new drugs with mouse, usually animal models, like they create in their lab a simulated type of MS-like condition called experimental autoimmune encephalomyelitis that they can create in these little rodents. And then they give them the drug and see how the animals respond. And this is because they're just new drugs that haven't been tested on humans and have to go through other testing with animals before they can be used with humans in clinical trials. So there's more trial and error than there would be in a clinical trial, but this is where you have to start. And I'm very optimistic that, I don't know if this particular agent will work out or not, but I know Dr. Tori Woodruff has recently published a study that sounded very promising. The results were very promising. And so we are, in the MS community, I know we're all grateful to our basic science researchers who are out there exploring new agents. And even if it takes a number of years for these agents to go through trials, and some of those agents are going to fall by the wayside, a minority of the agents will make it eventually and will probably be drugs that we'll be prescribing for people in years to come. So I think that's a really important component of everything we do in an MS program. Thank you. Did anyone have any other questions, comments? Been a wonderful group.
At this time, you're also welcome to unmute yourself if you'd like to speak up. I know some of you may not have access to chat. We'll just have to be careful depending on how many unmute at the same time. There's a new question from Antoinette.
Oh, okay. So commenting, having had MS since 2009, and if I may read the question. So this has been shared with everyone, right? So with your permission, I'll read some of this. So 19-year-old son having stabbing head pains. Oh, yeah, and had a CT done. You're saying they saw a cyst, did an MRI.